Hello everyone and welcome back to Clinical Cousins YouTube channel. Today we're going to continue our discussion on the nephron. We're going to be talking about the workers in the urine assembly line that come after the proximal convoluted tubule. Okay, so we talked about these workers in the assembly line in our last video. We know that they do a lot for us. So now we're going to talk about something a little bit more straightforward. We're going to be talking about the loop of Henle, as it's called. So we have our thin descending limb, we have our thin ascending limb, and then we have our money maker, our thick ascending loop of Henle. So we know that the proximal convoluted tubule guys did a lot. They did a lot of reabsorbing, and now we're going to see what the thin ascending loop of Henle, the thin descending, the thick ascending, we're going to see what that does for us, and it's really going to deal with solutes. So right off the bat, I want you to know this simple fact. The deeper that we go in the kidney, the saltier the kidney gets. So remember that. The deeper you go into the kidney, the saltier it gets. Okay, so let's pretend this is the top of the kidney that we're talking about. Say it's about 200 milliosmoles. That we should know that our blood is around 300. So it's a little salty up here, but the deepest part of the kidney could be anywhere from 12 to 1400. So really salty down here. That's why a lot of people don't eat kidneys, but they eat other organ meats. So let's talk about why that is. Okay, so proximal convoluted tubule. Then we have thin descending loop of Henle. We're going to call him the concentrator. He's going to concentrate our pre-urine. Now, this part of the nephron, it's diving deep. It's losing its salt. It's losing its water, but it's really going to help us form this concentrated urine. So that's why our juxtamedullary nephrons, remember those ones with the really deep, long loops of Henle, they help us make concentrated urine. Why is this so? Because they have these long loops that reach down into the saltiest part of the kidney. Okay, so we have our concentrated urine. It's very concentrated at this point. So what's next? We're going to move into the thin ascending loop of Henle. So we're going to call this guy a diluter. He is a diluting segment, okay? So the thin ascender, he loses its solutes, but it actually holds on to its water. This part is impermeable to water. So next we have the thick ascending loop of Henle. This is the really important guy, okay? So this is the star of our show, and it is going to likely affect every single one of your lives. You're definitely going to give a medication that affects this part of the nephron right here. This thick ascending loop is also a diluter, but the only thing we have to remember about this guy is that he has a special channel. It's called the sodium-potassium 2-chloride cotransporter. It doesn't sound very cool, but it's arguably one of the most important parts of the nephron. It's my favorite part to talk about. This is because 25% of sodium reabsorption takes place here. That is a ton of sodium. You have to think, these nephrons are processing 180 liters of fluid per day or more. So, I mean, 25% of our sodium, that's a lot. This is a very important job. So, in fact, this is so important, it's so good at its job, that the more sodium we throw at it, the more it's going to reabsorb. So, this is why diuretics that work in this cotransporter, they're very powerful. And I know what you're going to say, and this is exactly what I thought too. Well, Christian, wouldn't diuretics that work on the proximal convoluted tubule be more powerful because they reabsorb 67% of our sodium? And that is a great thought, and it's close, but with no cigar. Okay, so the sodium that stays in the tubule after the proximal convoluted tubule, it gets picked up by the thick ascending loop of Henle. So these proximal convoluted tubule diuretics, let's say that you inhibited all the sodium reabsorption here. All that sodium, it's going to get picked up by our different cotransporters, especially in the thick ascending loop of Henle. So that is why diuretics that work in this segment are much more powerful. Okay, so thick loop of Henle, the big guy, how does he work? Well, there's a sodium-potassium 2-chloride transporter, and it does exactly what you think. It literally moves sodium, potassium, and chloride from our tubule, from our pre-urine, into our blood. So we're saving it, okay? So we're reabsorbing sodium, potassium, and chloride, okay, but not water. This guy's a diluter as well, and there's something very interesting that happens, okay? This is going to have some clinical implications for us later. So potassium actually it's reabsorbed, but it actually leaks out into the lumen. Remember, the lumen is the inside of something. So the inside is filled with positive potassium. Okay, so this positive potassium, remember, too many bachelors here, too many positive bachelors. They want to go away from each other. So calcium and magnesium actually get reabsorbed. They get pushed. This positive push pushes calcium and magnesium to be reabsorbed back into the blood. Now, enter day shift nurses' least favorite drug. We're talking about Lasix. We're talking about Furosemide, right? This is a powerful diuretic, a powerful water pill as they call it. They're called loop diuretics because they work on the loop of Henle. That's where they get the name from. Okay, so furosemide, Lasix, it is actually going to block this co-transporter. Okay, so we can anticipate what's going to happen. So we know that, what are we going to lose here? We're going to lose sodium, we're going to lose potassium, we're going to lose chloride, and then what happens here? Well, if we don't have that potassium to sneak back out and make it positive, if it's already gone away, then what can't we shove between our cells? We're going to lose calcium, we're going to lose magnesium. Okay, so if there's no potassium to leak out, then there's no positive push to reabsorb that calcium magnesium. Remember, where are we reabsorbing to? Always the blood. Okay, so what does Lasix do, right? It is going to cause more sodium, potassium, chloride, magnesium, calcium. They're going to be lost in the urine. They're not going to be put back in the blood. They're going to be lost in our urine. They're going to be peed out of our body along with water, right? So the reason why furosemide can be used to treat hypercalcemia, too much calcium, hypermagnesemia, too much magnesium, when their patient has flash pulmonary edema, hypertension, congestive heart failure, the reason why it is going to treat that is because we are going to rid our body of fluid and certain electrolytes, right? It's going to be peed out, and also it's going to decrease our blood volume, which means a decrease in blood pressure. Okay, so I know you're excited to push Lasix into your patient because you don't like the day nurse, and you want to make your patient better, but also you want to make your patient pee a lot. You want to see that nurse that you don't like run up and down the floor trying to take the patient to the bathroom in time before they fall. Well, we have to slow down. This medication is ototoxic. I know you can't see my ears right now. I'm wearing a beanie. But if you push it too fast, it can cause tinnitus to occur in your patient, that constant ringing or clicking sound. Also, we have to check the patient's blood pressure. And this confuses a lot of people. If it's low and you see it's their first time taking the medication, you're going to push it slowly. Always follow your facility's protocol. But usually, if Grammy's been taking the medication for 20 years, you're probably not going to see a big drop in her blood pressure because the body is used to it. It's expecting to get that furosemide, that Lasix. However, if your patient has just had a heart attack, they don't take medications, they're very new to this medication, make sure their blood pressure is extra stable, and be sure to put 3 side rails up. Tell them to get up slowly so they don't get dizzy. Use a call light, or else you might hear a loud thud, and then you might have to rush to treat your patient's new head trauma and do neuro checks, and that is no fun. Okay, so for your patients on Lasix, be aware, we are going to lose a lot of potassium, and we'll talk about why that is later in another video. But you can anticipate we're already losing potassium right here, and we're going to lose more down the road. So we know that if we're losing potassium, we have to replace the potassium in our diet. That means they're going to have to eat lots of fruits and vegetables. Your dark leafy greens are going to be their new best friends. And chances are, if your patient is needing Lasix and you practice in America, your patient probably lives on a diet of fried chicken, biscuits, and Crisco, right? So this will be a huge change for them. So definitely make your dietitian your best friend, because you are going to need them to convince your patient to make lifestyle changes, although most of the time it doesn't usually work. So as always, thank you so much for taking the time with us to learn today, and remember to like and subscribe for more content, and we can't wait to see you next time. Thank you.